topic given to me is NOAC Navigation and CCS, a paradigm shift in CCS management. The good news is NOAC and CCS has come to stay. It's safe, effective, and promising. Better compliance and adherence, and is useful in CCS with SPAF and staff, and in CCS with atrial fibrillation. No monitoring is required. Quick onset of action and quick offset of action. It can be a first-line management after first year of management of ACS. Low dose with no bleeding or low bleeding risk. Low drug interaction and is cost-effective. And there is data to show that there is enormous morbidity and mortality benefit. An antidote is also available. The bad news is NOAC has also limitation. We can't use in the eGFR less than 15 and hepatic insufficiency, and there is a black box warning for metallic valve for NOAC. In NOAC and CCS cannot be used in pregnancy, in lactating mother or malignancy, or especially in antiphospholipid syndrome. I think everybody will like to give a tribute to our eminent principal investigator, Dr. J.W. Eichelboom from Canada, who has been the pioneer on COMPASS trial, with showing the relevance of rivaroxaban low dose along with the aspirin in CCS. You see the historic aspect of anticoagulants. It's almost 100 years. In 1920, it was MacLean who brought the concept of heparin. And then Stuart Connolly was another person who had a tremendous contribution in atrial fibrillation. So we are doing 10 years of celebration of NOAC in atrial fibrillation and CCS. The history of CCS is only 3 years. If you see the ACS management by
details of Kaushal Pandey.
Coronary intervention followed by effective pharmacological intervention, and ACS, instead of DAPT, we use P2Y12 monotherapy, which is safe and effective. And even after 3 months, we can use this as a monotherapy or along with aspirin. ACS is quite common. It's underestimated. And NOAC, rivaroxaban 2.5 milligram BD, along with the ASA, is a promising, effective, and morbidity and mortality benefit are shown. Now, what is my agenda? The agenda is I'd like to highlight the burden of CCS in India and Southeast Asia. NOAC navigation is CCS is the need of the hour. And to evaluate NOAC safety, efficacy, and outcome evaluation, as well as the mortality and morbidity benefit, especially in CCS, and to compare versus hazards. This is by European Heart guidelines. We divide coronary artery disease into acute ACS as STEMI, non-STEMI, and unstable angina, and CCS as stable angina, new heart failure, stabilized symptoms of less than 1 year post-PCS or post-PCI, and stabilized symptoms of more than 1 year, and patient with angina or microvascular disease, and asymptomatic with CAD, which is detected on screening. CCS is a dynamic process between the high risk and the low risk. When I say high risk, means a vulnerable patient in vulnerable age with vulnerable plaque and vulnerable vascular profile and vulnerable coagulation cascade. They're all the factors with enormous comorbidities. That's how we say CCS is very dynamic as compared to what we see in ACS. I have my case presentation. A 56-year-old male came in the ED with the history of chest pain, who was old, hypertensive and diabetic. Blood pressure was normal, heart rate was low, and his ECG revealed acute inferior infarction. Prop I was positive. It's very obvious here. And 2D echo revealed inferior wall hypokinesis, and the diagnosis of inferior wall STEMI was made and was immediately shifted to the cath lab and was given P2Y12 along with the aspirin as a loading dose. Why P2Y12 ticagrelol? Because the IPA at 30 minutes is 41% and IPA at 2 hours is 89%, which is enormous as compared to clopidogrel or prasugrel. Ticagrelol plus aspirin and statin loading dose is a very, very important prerequisite pre-cath, pre-PCI. And the patient underwent PTCA, and we see here there was a 100% block in the RCA, which was completely recanalized. Post PCI and discharge, oral antiplatelet drugs were given in the form of, you see the data from Plateau study. The Plateau study has shown very clearly ticagrelor may reduce the CV events from 30 days to 12 months, which is very, very significant. And we see here the ticagrelor versus clopidogrel. The data is very clear. Primary outcome, especially the MACE as well as the revascularization rate, is reduced by 53%. So ticagrelor is superior as compared to clopidogrel, is no more used anymore. Now, what are the limitations of prasugrel? There is a very major bleeding incidence with the prasugrel, and the overall TIMI major bleed, we see that there is a limitation beyond 75 years of age, and we have to titrate the dose by the weight of the patient. Ticagrelor is a promising drug with one-stop solution, and the level of evidence is mentioned here, as well as the class of recommendation is also mentioned here, regardless of diagnosis, whether it's a ACS or non-ST elevation MI or ST elevation MI or CCS, medical treatment or PCI or CABG or fibrinolysis. Across all characteristics of the patient, the ticagrelor can be used. And this is the patient, when patient discharged, is on ticagrelor and not on clopidogrel along with the aspirin. Shift the DAPT to ticagrelor as a monotherapy after 3 months is strongly recommended. And showed the data by Twilight study, which was published in 2019, we show in almost 7,000 patients that the bleeding risk is least with ticagrelor as compared to other drugs. ACC and HA recommendations are known to all of us that we have to give DAPT at least for 1 year after PCI. And therefore, in these patients, ticagrelor was given for about 90 milligram BD. Now the question, after 12 months, what should we do? After 12 months of PCI, are the patients stable, unstable, or chronic CAD or CCS? It's a big challenge now. And the data which has appeared from the REACH registry, the REACH registry has shown very clearly that prior ischemic events of more than 1 year is up to a tune of 17%. And the ischemic events after less than 1 year are 21%. It's a huge data to support that the ischemic burden is quite high even after 1 year of management with clopidogrel and aspirin. And see the data. MI, stroke, and CV death 1 year post-MI is almost up to a tune of 20%. Out of these 20%, 40% had MI, and 20% had stroke, and 40% CV death. And we see here the myth of stable coronary artery disease. Is it reality or it is a myth only? Because the data is very clear that a lot of patients have events. Should we call this as a stable CAD? I personally feel EC recommendation is we should label all these patients as CCS and not as stable coronary. So SAPT versus DAPT versus DPIT is a real question now. DPIT is a dual pathway inhibition therapy. And see the data. If you see a single antiplatelet drug which increases the CV events, especially with the aspirin, the MACE rate is 19% and the mortality is 9%. And the stroke rate and MI rate is also very, very high after 1 year. And see the data here with ticagrelor. Ticagrelor has no role so far as the mortality is concerned. The mortality reduction is not there. The SAPT and DAPT, no mortality reduction. MACE reduction is definitely there and is significant. There is no significant benefit in the CV death reduction, no significant benefit in all-cause mortality reduction, and no significant benefit in the major adverse limb events. So optimization of vascular protection is the need of the hour. And that's how DPIT, that is reducing the platelet activation and thrombin generation and CCS, was thought upon. And we see here the rivaroxaban is the drug of choice which reduced the continuous active thrombin generation and platelet activation, which is a very, very important factor to reduce the platelet aggregation and thereby synergizing the effect of anticoagulant and antiplatelet drugs and providing a complete vascular protection. So dual pathway inhibition therapy optimized the vascular protection in CCS. Rivaroxaban 2.5 milligram BD for CCS. Why it is a preferred choice? The answer is given by the COMPASS trial. You're all aware of this trial, which is a cardiovascular outcome for people using anticoagulant strategies from 2017. The objective of this trial was to determine the efficacy, safety of rivaroxaban, low dose rivaroxaban with low dose aspirin, along with reducing the risk of MI, stroke, and cardiovascular death. The total number of patients were 27,000, and they were divided into 3 groups: aspirin alone, rivaroxaban alone, and a combination of the two. And we see here the criteria of inclusion is very well mentioned here. Age was a criteria, the risk factors of ischemic burden. Same was done in PAD. The ischemic burden, especially by ABI, ankle brachial index, as well as by the ischemic episodes of PAD. And we see the data. The vascular dose of rivaroxaban and aspirin showing a reduction of MACE by 24% and the CV death by 22%. And the overall mortality rate is reduced by 18%. This is the only drug in the world, in the universe, shown a reduction in the CV death after 1 year of DAPT, as well as the stroke rate reduction was almost up to the tune of 42%. COMPASS trial is also measured bleeding in the form of 2.3%. And we see the COMPASS trial subgroups, which is also shown there is a 70% reduction in the amputation rate by vascular dose of rivaroxaban and aspirin. WIGAR PAD study, which is also a very important study, and it has shown the primary endpoints, all the endpoints like acute limb ischemia, major amputation by vascular cause, myocardial infarction, ischemic stroke, and CV deaths are significantly reduced when the patient are given this combination of low-dose aspirin and low-dose rivaroxaban. And these are the clinical studies from 2007 to 2017. A Charisma study and PEGA study and COMPASS trial have shown very clearly that the risk reduction of MACE, CV deaths, and all-cause mortality was significant in COMPASS group as compared to the other series. A meta-analysis of 4 randomized clinical trials favors SAPT and oral anticoagulants as compared to VKA and DAPT. This is the ESC guidelines known to all of you. NOAC has been very well shown to a level class of 1 and level of evidence is A, especially in atrial fibrillation. And if you see here, the data is very clear that ESC guidelines 2019 adding low dose of aspirin, long-term secondary prevention should be considered in patients with a high risk of ischemic events. So our objective is we have to see the ratio of ischemic load and the bleeding load and accordingly decide to our patients. The level is 2A and evidence level is A. Consider low dose aspirin and rivaroxaban to reduce the adverse cardiovascular events and lower extremity ischemic events in patients with ischemic episodes. This is by global vascular guidelines in the management. It is very, very clear. Again, the level of evidence is 2B. Same way, we see the patient with angina or dyspnea, it is a level 2A and A. To conclude, ladies and gentlemen, after 1 year of ACS, CCS burden is quite high because of significant morbidities and comorbidities in our population. Vascular dose of rivaroxaban with low dose of aspirin prevent clot formation through DPIT strategy. We must individualize our patients on ischemia and bleeding risk ratio. It's very, very important. Since it's a low dose, the bleeding is rather very, very low. DPIT is therefore superior as compared to DAPT and SAPT in mortality and morbidity reduction. Rivaroxaban 2.5 BD is the only NOAC which is proved for both ACS and CCS by FDA. COMPASS trial has shown overwhelming efficacy in CCS and PAD patients so that it was terminated 12 months before the expected date of its completion. WIGAR PAD study has also shown significant benefits of 2.5 rivaroxaban and ASA in symptomatic PAD patients undergoing peripheral revascularization. So what's the message? The message is health of millions is at stake with CCS and comorbidities in India like hypertension, metabolic syndrome, and diabetes, and vascular profile of a vulnerable plaque in elderly population. Timely NOAC intervention with low-dose rivaroxaban is the need of the hour. DPIT is superior as compared to DAPT because of enormous mortality and morbidity benefit. We must act locally and impact globally by creating our own protocols in the form of studies. So the revised prescription now, after 1 year, has to change based on the data. We have to have rivaroxaban 2.5 milligram BD, depending on your patient's ischemic load or the tendency for the bleeding load. So I think this slide I always show you to go towards the lion or tiger. DPIT is lion and DAPT and SAPT is tiger. Choice is purely yours. Thank you very much for your kind attention.